Good afternoon. I am passionate about the imaging of fibroids. Hope you will be too. So here is my outline, and given that I have a lot of material to cover, we're just going to start. Why is this important now? And it's important now, or has gained notoriety now because of Dr. Amy Reed, who was a doc up in Boston. And Amy went in for presumed benign fibroid surgery. She was treated with a laparoscopic power morcellator, which is kind of like this pulverizing technique where it sort of pulverizes the uterus or fibroids. And unfortunately, it wasn't a benign fibroid. It was a leiomyosarcoma that got spread around her peritoneal cavity, and she died prematurely with 4 kids. Her husband, who survived her, has become a big advocate for being able to diagnose sarcomas that are presumed to be fibroids. And the goal for all of us is to detect a leiomyosarcoma before treatment for presumed benign fibroids. But distinguishing the two can be challenging, so much so that in 2014, the FDA issued a black box warning on laparoscopic power morcellators because there was an increased prevalence of unsuspected sarcoma and leiomyosarcoma in symptomatic women who had presumed benign fibroids, leading to upstaging of sarcoma. And this was their black box warning. Uterine tissue may contain unsuspected cancer. The use of LPNs during fibroid surgery may spread cancer and decrease the long-term survival of patients. And they said you had to discuss this with patients. Okay, all well and good. Then the FDA in 2020 said, you know what, we'll let you use those LPNs, but you got to do it within a contained bag situation. I don't really know, can you really prevent little pieces, wafting off outside the bag? Not for me to say, but it is a little curious. And then ACOG weighed in and said, there's really no way preoperatively to diagnose a sarcoma from what's a benign fibroid, although there is imaging. And then they said, but more data on the potential efficacy of pre-op evaluation with MRI is needed. And I would agree completely. But if you think the black box warning makes sense for laparoscopic power morcellators, what about UFEs, right? We're not getting biopsies and we're not getting histology before we send particles down the uterine artery embolization. So it's something to think about. And at least in our practice that does a lot of UFEs, we get MRs for every patient who's a potential UFE patient, just trying to separate out what's a fibroid versus what's a sarcoma. So can imaging really distinguish between a fibroid and a leiomyosarcoma? We're going to play the good witch, bad witch game. Here's the normal sagittal T2-weighted sequence of the uterus, high signal intensity of the endometrium, low signal intensity of the junctional zone, and intermediate signal intensity of the myometrium. I have 4 different patients. Each has a dominant mass, and we're going to decide good witch, bad witch. First case on your left, well circumscribed, low signal intensity, fairly homogeneous on T2. I'm going fibroid. Hopefully you're going to say fibroid too. We'd be right, 1 for us. Next one, a little heterogeneous, pretty irregular margins. I'm a little nervous. I'm thinking potential sarcoma. I'm right again. It's a sarcoma. Third case, well circumscribed, mildly heterogeneous, but again, well defined. I'm thinking on balance, probably a fibroid. Wrong, sarcoma. Fourth case looks a little bit like case number 2, irregular, heterogeneous. I was just burnt on the last case. I'm going sarcoma. Wrong. This was a degenerated fibroid. There is great overlap if you just rely on conventional imaging for distinguishing a fibroid from a sarcoma. And this is not just an academic discussion. This happens to real people. This was early in the Georgetown experience. This was in 2001. A patient came in, she was scheduled for UFE. We did the MR. I'm like, yeah, she's got a heterogeneous fibroid, but it's viable, send her for particles, So she has a technically successful uterine fibroid embolization. She came back for her 3-month follow-up and she felt better. Fibroid was smaller, still viable, not dead as a doorknob, but despite a technically successful UFE, but she felt better. 1 year later, it's bigger. And worse than that, she has metastases. And that's on me. I missed it before, and I missed it after. And I hope you don't ever have to have this feeling. I live with this case, and this woman is no longer with us. So the goal really is to detect sarcoma before treatment. But let's backtrack. Let's discuss the fibroid problem. Let's put it in context. Fibroids are really common. Almost 80% of path specimens of hysterectomies have fibroids. Black women are disproportionately affected. They have a greater incidence. They're more symptomatic, and they get more hysterectomies than white women. Moreover, it is a huge economic burden. This is fairly old data. I haven't seen new data, but upwards of $34 billion in both direct and indirect costs for fibroids. It is a huge problem for our society, not just women. Now, we do have treatment options, right? For symptomatic fibroids, you can give medicine, you can do surgery, you can do MR-guided focused ultrasound, or what we do, at least in the radiology practices, is uterine fibroid embolization. And we can argue which one's better. But the bottom line is, invasive, minimally invasive, and non-invasive therapies are here to stay. And as imagers, we're going to be seeing these patients. So what's the role of MRI? Well, the role of MRI, the goal is to diagnose fibroids, characterize them, triage patients to appropriate therapy, and follow them as needed once they've had therapy. This is in your handout. This is the protocol from the European Society of Uroradiology. Patients are fasted for 3 to 6 hours. They empty their bladder. They get an antiperistaltic, and we used a phased array imaging coil. The protocol's pretty standard, but what's really important is diffusion-weighted imaging is not optional. It's not a complete study unless you do diffusion-weighted imaging, and you need a B-value of at least 1,000 in order to use the algorithm that I'm going to share with you later. If you are going to be doing fibroids, we have to, again, it's lexicon, we have to talk a similar language. So you have to not only diagnose fibroids, you have to say size, number, and location. And we use this FIGO subclassification system. It goes from 1 to 8, or 0 to 8 being from inner to the outer aspect of the uterus. So for example, this is a type 3. It's an intramural fibroid touching the endometrium. This is a type 5. It's subserosal, greater than 50% is intramural. This is a type 6 where less than 50% is intramural. And this is a pedunculated fibroid, or a FIGO type 7. We also comment on whether there's ovarian arterial supply to the uterus, because both prograde and retrograde flow can be problematic. You can have a suboptimal or non-durable response if it's if it's prograde, or an inadvertent ovarian embolization in early menopause if it's retrograde flow. So we always comment on the presence or absence of ovarian arterial supply to the uterus. Moreover, not every woman that has fibroids is going to be symptomatic because of her fibroids. She may have alternative or comorbid conditions, and about 20% of UFE candidates are not appropriate for uterine fibroid embolization. And here's an example. It's a patient who had a history of leiomyomas. She presents with left lower quadrant pain. They thought, well, maybe she is having some sort of degeneration. Maybe she needs a uterine fibroid embolization. We do the MRI, sagittal T2 on your left. We see a posterior fibroid that's well circumscribed. We give contrast. There's no enhancement. You don't send particles down the uterine artery to kill an already dead fibroid. But because we're imagers and we're responsible for everything that we image, you can see that her left colon is markedly abnormal. It's thickened. There's inflammatory changes. She had diverticulitis. No, I'm not advocating MRI to be the initial modality if they suspect diverticulitis. But you'll realize that fibroids are ubiquitous, and sometimes what's causing pain isn't necessarily the patient's fibroids. What kind of treatment should this have? This patient also had pelvic pain. Axial T2, heterogeneous mass, T1 fat suppressed technique. We see hemorrhage, UFE, and I hope we could cue the Jaws music, but that's beyond my technical capabilities. This was another sarcoma. She doesn't go to uterine fibroid embolization. If she needs embolization, it's to control bleeding in the operative bed, but as a primary treatment, it's not UFE. And that brings us to the different flavors, as I call it, of fibroids. I think we all think about the ordinary fibroma, the classic fibroid, or the degenerative fibroids. But there also are leiomyoma variants and subtypes. There are atypical leiomyomas. There are stump tumors, which nobody knows. The pathologist can't even decide if it's cancer or not. And then there's the cellular subtype, and then the leiomyosarcoma, which is characterized by diffuse atypia, high mitotic count, and most importantly, coagulative tumor cell necrosis. And that's for the pathologist to see. And with increasing sort of bizarreness, we also expect increasing heterogeneity on T2-weighted sequences, but that's not enough to make the diagnosis. So what are the features of both classic and degenerated fibroids? And we'll move on to sarcomas after that. Well, we're radiologists. We love tables. I love tables. I'm the author of one of these tables. Unfortunately, these tables are a good start, but fibroids don't read textbooks. But certainly it's helpful to begin to think about fibroids when looking at a table and trying to classify their imaging features on different sequences. So the classic fibroid, or one that's undergone hyaline degeneration, which is the most common type of degeneration, you will see a well-circumscribed round or oval lesion on T2-weighted sequences. It will have low signal intensity on the high B value sequence and low on the corresponding ADC map, or as we call in the parlance, it's the blackout effect. And this is an image, I don't know if I was alive, of the 30 million people without power in the New York big power outage in a blackout in 1965. Blackout is good for classic or degenerated fibroids with hyaline degeneration. Cystic degeneration, as you may imagine, is low on T1, bright on T2, and the cystic components don't enhance. That's pretty easy also to diagnose. Hemorrhagic degeneration occurs when the fibroid outgrows its blood supply, or conversely, if you've had a successful uterine fibroid embolization, you now have what we think of as a bag of blood where the fibroid was. And these tend to be high on T1-weighted fat suppressed techniques with higher surround, low on T2 with lower signal intensity rim, but most importantly, they're dead as a doorknob. You give contrast, they don't enhance. So that's either going to be autoinfarction or a technically successful uterine fibroid embolization result. Leiomyomas, as Dr. Sheff mentioned earlier, tend to happen in the perimenopause or after menopause, bright on T1-weighted sequences without fat suppression. You give fat suppression on the next sequence, and they fall in signal. It's macroscopic fat. Again, pretty easy to make that diagnosis. Hydropic degeneration is fairly rare. I haven't seen lots of cases, but it has this sort of world effect where there's high signal intensity on T2, sort of circumscribing some nodules, which enhance following contrast. I think it looks like a cyclone. Having said that, it's very bizarre. No one would fault you if you raised a concern that you think this is more aggressive. I think it's hard to exclude something untoward in this case. Myxoid degeneration is very rare, and I'm thankful for that because it's a very strange looking tumor. It can have high signal intensity on T2. This is an axial image. And then following contrast, it shows gradual enhancement. I wouldn't make the diagnosis of myxoid. I would call this strange and bizarre, call up my interventional radiologist or clinical colleague saying, "Uncle, I really don't know and I'm worried." I think it's better to be overcautious than undercautious, especially if the patient's post her reproductive years. Cellular subtype is a really fun kind of fibroid. In this case, we see two classic fibroids, low signal intensity, well circumscribed, but anteriorly we see a well circumscribed mass that signal intensity is either equal to the myometrium or maybe a little higher. Moreover, when you give dynamic contrast, it enhances homogeneously. That is well circumscribed homogeneous enhancement, and it shows restricted diffusion. And if you have this constellation of imaging findings, you can be very confident that this isn't cancer, this is a cellular subtype of fibroid. But remember, not every symptomatic uterine mass is a leiomyoma. And this is an older case, but it illustrates the point. Woman had a CT, I don't even remember why, in September 2010, incidental fibroid, whatever, next case. She comes back 5 years later, basically in extremis. We do the MR, and she's having uterine rupture. She's bleeding out on our MR table. She survived, but scary, because this wasn't a garden variety fibroid. This was a sarcoma. It had grown, and she ruptured her uterus. Thankfully, she survived. So that brings us to uterine sarcomas. There's lots of different types. We're really going to focus on the uterine leiomyosarcoma, which is the most common type of sarcoma. It has no biologic link to leiomyomas. They are different animals. It's not like a fibroid dedifferentiates into a sarcoma. It doesn't. One's a sarcoma, one's a benign fibroid. LMSs tend to occur after the menopause. They tend to be solitary. They have this coagulative tumor cell necrosis on pathology and unfortunately carry a really poor prognosis. And again, it can be really hard, like those first 4 cases, to differentiate it. And unfortunately, all the work that's been published on it have really been either small studies or they've aggregated leiomyosarcomas with other uterine sarcomas. So it's been hard to exactly tease out what are the specific characteristics, but we're getting closer. I am not going to go through all the data. This was from 2017, done at a Memorial Sloan Kettering, where they had 19 LMSs, some typical fibroids, for a total of 41 cases. And they looked at 3 different sort of imaging characteristics: ill-defined heterogeneity on T2, hemorrhage, and central-ish non-enhancement, and found that if a patient's lesion had greater than or equal to all of those 3 features, there was a pretty high negative and positive predictive value, but recognizing only 19 leiomyosarcomas. So can ADC help us, right? Can it help us distinguish between a benign fibroid and a sarcoma? And these are listed in chronologic order. And you'll notice there's not a lot of sarcoma LMSs in this either. The largest was in Wahab et al., and that was out of Canada, where they had a study of 105 fibroids, 3 stumps, and 48 sarcomas. But if you look even more closely at this chart, recognize those ADC values are all over the place. I don't know what to use. Are you going to use Wahab? Are you going to use Lin? It's how do you make generalizations if we can't even agree on one ADC? So I love this cartoon. No, Jacob, we don't have to agree to disagree. We need to have a uniform approach that all of us can use in our practice. In general, the ADC of a sarcoma is less than the ADC of a fibroid. Remember, classic fibroids have that blackout effect, that dark. This is the 77 New York blackout, and notice the Twin Towers were still standing. And this is, beneath that is leiomyosarcoma, bright on diffusion-weighted imaging, 1,000 B value, and falls in signal on the corresponding ADC map. So we should theoretically begin to be able to separate out fibroids versus sarcomas by using multi-parametric imaging. So we are circling the diagnosis. But how do we use this information to screen for a sarcoma? Well, we need an algorithmic approach, right? So that we're all on the same page and reading them similarly. And I'm going to scare you now because you think I'm going to go through all of these. I'm not. We're going to try to summarize it, but there are many algorithms out there. One that came out of NYU, done by Angela Tong, was more of sort of a gestalt, or looking at different characteristics of lesions that were in classic fibroids. Did it have irregular borders? Did it have high signal intensity on T2? Was there hemorrhage? Was there central non-enhancement? And did it have restricted diffusion? And they grouped their findings into low risk, those patients that they were really certain that it was not going to be a sarcoma, and those patients went to laparoscopic myomectomy, versus the patients they considered high risk, and they had a 2-step procedure, meaning they had a biopsy of their mass, and then if it was benign, it was removed. And, you know, their positive predictive value, not too great, although they had a very high negative predictive value, meaning if you felt it was not a sarcoma, you were going to be right. So again, moving in the right direction. And we'll just look at some cases. This is a heterogeneous mass with irregular margins, check, check. It does have hemorrhage. It has central non-enhancement, and it has restricted diffusion. I'm going sarcoma, I'm going bad witch, and I'm right. What about this case? Well circumscribed, so it's not irregular T2 margins. It's not really heterogeneous. It has sort of intermediate signal intensity, no hemorrhage, no central non-enhancement, and it has restricted diffusion. Well, this looks very much like the cellular subtype that I showed you before, and this is a cellular subtype fibroid. But what about this case? Okay, it's irregular T2 margins, right? Heterogeneous signal intensity, kind of looks almost like that myxoid one, or maybe the hydropic one. It looks funky to me. No hemorrhage, no central non-enhancement, and it has restricted diffusion. You know, uncle, I give up. And that we'd be right, because it's a stump tumor. The pathologists don't even know what this is. So how do we expect us to do it at this point? But it's fair to say is this is not a classic or any type of degeneration that I know of, nor is it a cellular subtype. I'm worried we need to go further. And this was probably the largest study to date. This is out of, like I said, McGill. This was a case control, large retrospective study that had a training arm and 2 validation arms. And it's, in my mind, and it's in your handout, it's pretty complicated. You have, you know, obviously if there's enlarged lymph nodes and peritoneal disease, yes, we know it's going to be suspicious. But then they looked at the T2 signal of the solid tumor, or what they called low area in a heterogeneous mass. I actually don't understand what that is, and I don't feel like I'm talking out of turn. I've talked to the authors. I don't really understand what that means. Then they looked at the diffusion-weighted signal, and then they calculated ADC values and looked at those. And actually, this algorithm in their hands performed really well. In fact, identifying up to 95% of masses correctly. So I do believe there's a lot of valuable information in there, but I was challenged by it, and so were others. So under the guidance of Nicole Hidman at NYU, we came up with a consensus statement of how to approach these uterine masses. And I think this is an easier algorithm than the one I just showed you. And I actually think it is very doable in most of our practices. Has it been validated? No. Do I hope someone out here in the audience might do it? Yes. But I do think if you're struggling, this is a really nice approach that you can share with your colleagues. So basically, if something's not a classic fibroid or not, autoinfarcted or a cellular subtype, it's called an atypical uterine mass. Obviously, if there's extrauterine disease and ascites, you know that the patient, has a malignancy. But if not, you have to look at the T2 signal of the solid enhancing component. So, look at the T2 signal of the solid enhancing component. And if that is intermediate to high signal intensity, then you have to go to diffusion-weighted imaging. So then you look at the diffusion-weighted signal of that solid element, and you look at it on the high B value, at least 1,000. That's the image you have to look at. And if that is higher than the endometrium, and if you can't see the endometrium, higher than the lymph nodes, then you need to calculate your ADC values. And if that ADC value is less than 0.9, that is suspicious for malignancy. And it really is a stepwise fashion. And if all those criteria are satisfied, you really should raise concern that you are dealing with a sarcoma. So what are the takeaways from that? Features suspicious for sarcoma include enlarged lymph nodes and/or peritoneal implants, enhancing solid elements, ones that are heterogeneous on T2-weighted sequences, that is, they're either intermediate or high signal intensity. They have a high diffusion-weighted signal intensity. Again, that B value needs to be 1,000. That's what at least the McGill study was based on, and we're using their ADC value. And it has to be high and greater than or equal to the endometrium. If you don't see the endometrium, compare it to the lymph nodes, and the ADC value's got to be less than 0.9. So how do we communicate this? Because I've thrown a lot of info at you. Well, structured versus narrative reporting of pelvic MRI for fibroids, clarity, and impact on treatment planning was a study done out of Boston. And what they found was that structured fibroid MRI reports missed fewer key features from narrative reports. Moreover, structured reports were described as more helpful for treatment planning and easier to understand. And I'd say not only for treatment planning, but also for surveillance. So how many, I can't see all that well, do use structured reports for pelvic MRI? Yeah, I think it's pretty easy because there's drop-down menus. You can put in the FIGO type. You don't have to really think that much. And once you get used to it, it's really quick, and it makes it very easy, at least, to follow patients in between different types of therapy. Remember, not only before treatment, but after treatment, because again, here's my miss. I missed it in 01, and 3 months later, I missed it in 02. And so I hope that you're beginning to get a sense that, with a little diligence and learning how to use multiparametric imaging, you'll be able to find these sarcomas before the patient has the wrong treatment. So multiparametric findings are helpful, but are they everything? Because I've made it kind of sound very easy. There's fibroid characteristics and sarcoma characteristics, and maybe they're dichotomous, all one type and imaging features of the other type. But life doesn't work that way. And again, fibroids don't read textbooks. Because a classic fibroid or a degenerated fibroid can be solitary. Showed you a case that had irregular or lobulated morphology. They certainly can be heterogeneous based on their degeneration. They can have red degeneration, so that's hemorrhage, right? So you're going to see hemorrhage. You can have central non-enhancement if it's a cystic fibroid. That one cystic fibroid I showed you had no central enhancement. And cellular degeneration subtype can have restricted diffusion. So as you can see, these are not as dichotomous as we'd all hope for, and that's too bad, but that's life. And there certainly is overlap between leiomyomas, leiomyosarcomas, and atypical fibroids, but all is not lost. What are our future directions? The future's kind of now, right? It's machine learning, and there are multiple studies out there, and you can't really open up a journal either in print or online without seeing someone doing something about machine learning or AI or whatever the words that you want to use to describe what's sort of coming down the pike. I can't say that I am an expert on any of this. This computing power is knowledge way beyond my own neural network, but this is clearly the future, which I think we will be able to use that to help us better define what's a fibroid and what's a sarcoma. So that is definitely the future. So by way of conclusion, fibroids are ubiquitous. You know, you're going to see them, right? If they're in 80% of pathologic specimens, a woman comes in for a pelvic MR for whatever reason, you're going to see fibroids. But I think a big referring pattern is any patient, at least in the radiology department, that is going to have a uterine fibroid embolization should have an MRI. It should be done with contrast, and you have to use diffusion-weighted imaging. The prevalence of sarcoma is higher than previously reported. If you think back to your medical student days or your residency days, it was like, yeah, 1 in 10,000, whatever. It's up to like 1 in 300 of these are symptomatic patients, not all patients with fibroids, but 1 in 298 patients that have symptomatic fibroids will have an undiagnosed sarcoma. You're going to see them. They exist. You will see them in your practice. We really need to be able to reliably differentiate fibroids from sarcomas prior to intervention, or at least raise a concern for sarcomas. Sometimes you don't know and you have to be honest, but you have to raise the concern and get on the horn, call your IR docs or call your referring clinicians and say, hey, this isn't a classic. It's not any of the degenerated ones I can diagnose. You know, it's not a leiomyoma. I am worried about this. It has restricted diffusion, a low ADC, and this could be a sarcoma. MRI can certainly help, but we have to use our multi-parametric approach. But I think most of us would agree that more work needs to be done. And moreover, we all need to work together. And I am really lucky. We have a monthly fibroid, / endometriosis conference, where we sit with our MIG surgeons, minimally invasive gynecologic surgeons, and we talk about cases. We talk about where we hit a home run and where we didn't hit a home run. And we learn from those cases, and it's been really helpful. And remembering that the patient is always central to what we're doing, right? There's a woman that's at every case. And again, I would just ask you to sort of think about Amy Reed and the lessons she has taught us, though she did not live to see all of those. So thank you for your time.